You know, um, Usually when we talk about measuring vital signs in clinical practice, there's this expectation of absolute precision. Like you look at a heart rate monitor, it flashes 80 beats per minute, and you just point and say, there it is. High or low, fast or slow, it's clean.
Right, but it provides this totally false sense of security, honestly. We
Yeah.
rely heavily on those objective, discrete numbers because they fit perfectly into a flow sheet. But that binary logic completely collapses the moment you step into the world of pain assessment.
Oh, it is the absolute definition of diagnostic muddy waters.
Yeah.
And today, our mission in this deep dive, is all about mastering the art and the rigorous science of the nursing pain assessment.
It really is an art and a science combined.
Yeah, exactly. We're diving deep into an incredibly specific set of notes designed for advanced nursing practice, alongside a really comprehensive presentation by Dr. Sean M. Reed. He's an advanced practice registered nurse whose work focuses intensely on the complexities of assessing pain, particularly in older adults.
Which is an incredibly nuanced population to work with.
Definitely. So our goal today is to look way beyond that standard, 0 to 10 scale and uncover the intense detective work required to truly understand what a patient is experiencing.
And that requires a fundamental shift in how you approach the bedside. I mean, a nursing pain assessment is never just about recording a number and moving on to the next task.
All right.
It demands synthesizing the patient's history, their physical presentation, and their deeply personal narrative. It
Right.
is arguably the most complex critical thinking exercise you perform during a shift.
Okay, let's unpack this
Mhm.
because we have to begin at the very first step of any patient encounter, right?
Yeah.
Finding out why they're in pain and where it came from, the etiology.
Exactly, the root cause.
So Dr. Reed's framework emphasizes taking both a recent and a distant history, but looking way beyond just the obvious physical trauma.
Yeah, you have to expand the timeline and the context. You aren't just looking for a mechanical mechanism of injury like a fall or a sprain. You are mapping the onset of the pain against psychosocial events.
Like what kind of events?
Well, did the pain spike immediately following a major life change? Or did it become completely unmanageable right after they received bad news about their prognosis?
Oh, wow. Which makes perfect sense when you think about the sympathetic nervous system.
Yeah,
Like bad news triggers a fight or flight stress response, right?
exactly.
It dumps cortisol and adrenaline into the bloodstream, which increases muscle tension and massively amplifies the perception of pain. The physical and the psychosocial are sharing the exact same neural pathways.
And this is why gathering the history is so incredibly nuanced. You are navigating those pathways with the patient. Now, you absolutely want to involve the family or caregivers in this process to establish a baseline, but, and this is key, the older adult's own self-report remains the gold standard.
The ultimate truth for that patient.
Right. It is the most valid measure of their pain, period.
But, that creates a really fascinating friction point for a nurse. What happens when a patient insists they are a 0 out of 10, but they are diaphoretic, tachypneic, and wincing with every single breath?
It's tough.
You prioritize their self-report, sure, but you can't just ignore the physiological data right in front of you.
You don't ignore it at all. You use it to guide your physical exam. You move systematically through palpation, auscultation, and percussion to gather objective findings that either support or challenge that verbal report.
So you're actually getting hands-on.
Yes, you are assessing for localized tenderness, listening for abnormal bowel sounds, or checking for trapped fluid and gas alongside full neurological and mechanical exams.
It's like tracking down the source of a water leak in a house.
Oh, I like that.
Yeah, like if you see a water stain on the ceiling, which is the patient's complaint of pain, you don't just stare at the stain. You have to trace the plumbing. You check the roof for structural damage, which is your distant history.
Right.
You run the water to see when it leaks, which is your mechanical exam. And then you have to decide if you actually need to tear down the drywall to see the pipes.
That is a perfect analogy
Got
because
it.
that decision to, tear down the drywall translates directly to how you approach labs and diagnostics. You have your blood panels, your analysis, x-rays, CT scans, MRIs, ultrasounds.
The heavy machinery.
Exactly. But you have to constantly weigh the diagnostic benefit against the physiological and psychological burden of the test itself.
Which is a huge consideration for older adults.
Yeah.
I mean, if you have a frail 88-year-old patient with advanced dementia who is in severe distress, putting them through an MRI is a massive intervention.
It's incredibly taxing.
You have to transport them, position them flat on a hard table, subject them to loud, terrifying noises in an enclosed tube.
Yeah, so you have to ask yourself, will results of this MRI actually change my nursing care plan today?
Right.
If the intervention required to fix what the MRI finds is way too aggressive for the patient's current state, then the imaging only serves to satisfy clinical curiosity.
Yep.
It offers no therapeutic value, and honestly, it just inflicts more trauma.
You have to consider the whole person, evaluating whether the burden of the test outweighs the potential benefit.
Always.
So once we have that history, and we've done our physical exam and carefully considered our diagnostics, we move into the geography and the math of pain. We need to map it on the body and measure its intensity to establish a functional baseline.
And the location tools are highly systematic. You are utilizing dermatome maps to trace nerve root innervation down the extremities and having the patient interact with generalized pain maps to isolate the physical origin.
Yeah, and then comes the math, right? The intensity scales. We utilize the simple descriptive pain distress scale, the visual analog scale, and of course the classic 0 to 10 numeric pain distress scale.
The standard.
But I really want to push back on the utility of that 0 to 10 scale for a second. If a patient tells you their pain is a 7, how does a nurse actually operationalize that data? Pain is entirely subjective.
Right, it's relative.
Like a 7 for me, based on my life experiences, might be a 4 for you.
You are hitting on a major limitation of viewing that number in isolation. The number itself is clinically meaningless unless it is contextualized by 3 distinct measurements:
Which are?
the historical pain, the current pain, and the goal or acceptable pain.
The concept of goal pain is brilliant. It completely reframes the objective. It's like setting a monthly financial budget.
How so?
Well, you can't always aim for 0 expenses. You have a mortgage, you have groceries, utilities. If you try to spend $0, your household falls apart. The goal of a budget isn't 0, it's getting your expenses down to a manageable level so you can still function and thrive.
That's a really grounding way to look at it.
Yeah, in clinical practice, the goal pain is rarely 0. It's whatever level allows that specific patient to comfortably eat, sleep, participate in physical therapy, and just interact with their family.
What's fascinating here is that establishing that functional goal shifts the entire paradigm of care. It moves the nurse and the patient away from the unrealistic and often dangerous pursuit of total pain elimination.
Which usually just leads to oversedation.
Exactly. And moves them toward functional rehabilitation. And achieving that goal requires you to understand the pattern of the pain.
Right, because the pattern dictates the pharmacokinetics of your intervention. Is the pain constant? Is it episodic, meaning it comes and goes with periods of 0 pain in between?
Yeah, or is it a constant baseline ache with sudden spikes of breakthrough pain?
Right. And the pattern tells you how to time your interventions. If the pain is purely episodic, a PRN, short-acting medication, makes sense.
That's absolutely.
But if it's constant, you need round-the-clock baseline coverage with long-acting agents. If you treat constant pain with intermittent PRN dosing, you are just chasing the pain all day, allowing the patient's nervous system to repeatedly wind up and sensitize.
And you'll never catch up.
Here's where it gets really interesting, though. We have the intensity number, we have the location map, and we have the temporal pattern. But the actual words a patient uses to describe the quality of their pain,
Yeah.
those descriptors tell the nurse exactly what anatomical system is failing.
Language is high-fidelity clinical data. It really is. Dr. Reed's notes break this down into 3 distinct physiological categories. Let's start with nociceptive visceral pain.
Great.
This stems from an injury to the internal organs. So perhaps a venous occlusion, ischemia, or severe ascites just stretching the abdominal cavity.
The descriptors patients use for visceral pain are incredibly specific, right? Cramping, gnawing, deep squeezing, pressure, stretching, bloated.
Yeah.
And the crucial takeaway from the sources here is that visceral pain is poorly localized. The patient knows their abdomen is in absolute agony, but they can't point a single finger to the exact source.
There is a really fascinating physiological reason for that. Visceral organs have a much lower density of sensory nerve endings compared to your skin.
Okay, that makes sense.
Furthermore, those visceral afferent nerves converge on the exact same spinal cord pathways as somatic nerves. So when a signal comes up from, say, an ischemic bowel, the brain gets a generalized distress signal, but lacks the neurological mapping to pinpoint the exact coordinates.
Wow.
That's why it feels gnawing and diffuse.
Now, contrast that with nociceptive somatic pain, which involves injury to the musculoskeletal structure, so the bones, joints, and muscles.
Right.
The descriptors change entirely to aching, dull, throbbing, or sore. And unlike visceral pain, somatic pain is sharply localized.
Because the skin and muscles are densely packed with nociceptors that correspond to a highly detailed map in the brain's somatosensory cortex.
Ah.
If a patient fractures their femur, they don't just complain of a vague ache in their lower half, they can point to the exact millimeter of the break.
Then we have the third category, neuropathic pain. This is an injury to the peripheral or central nervous tissue itself. And the language here sounds almost violent, honestly. Numbing, burning, radiating, shooting, electrical, tingling.
It sounds violent because the mechanism is essentially a neurological short circuit. You are dealing with ectopic firing of damaged nerves.
The nerve isn't just transmitting a signal about tissue damage anymore.
No, the nerve itself is the site of the damage, firing off spontaneous, chaotic signals.
I just love how precise this vocabulary is. Recognizing that gnawing implies a visceral organ issue, while shooting indicates a nerve pathway problem, it completely changes your assessment.
It really does.
But how do you help an exhausted, suffering patient find these specific words if they are really struggling to articulate what they are feeling? You can't just hand them a dictionary.
No, you definitely can't. You utilize careful, guided interviewing. You provide a menu of descriptors without leading them to a specific conclusion.
Like giving them multiple choice.
Yeah, you might ask, does the pain feel more like a dull ache, a tight squeeze, or a burning sensation? You are giving them the vocabulary to accurately report their physiological state.
Which bridges the gap between the mechanical cause of the pain and their actual lived experience of it.
Exactly.
Which brings us directly into the concept of meaning and interventions. Because once we understand the anatomical mechanics, we have to address how this pain is actually impacting the patient's life. Dr. Reed introduces this beautiful concept of caring curiosity.
Yeah, it involves approaching the patient's experience through the lens of an illness narrative. You are moving beyond the physical symptom and asking what the pain represents to them on a psychosocial level.
The phrasing suggested in the notes is so powerful. You ask open-ended questions like, tell me what it means to have a 7 out of 10 pain. What does that mean for your daily life? What would you do if your pain was a 5 out of 10?
That shifts the entire dynamic of the nurse-patient relationship. If the patient responds, well, if I was at a 5, I could finally stand up and cook a meal for my spouse, you have just identified their quality of life goal.
Right there.
And quality of life is strictly defined by the patient's personal wishes and values, never by a clinical textbook.
You also have to investigate the aggravating and alleviating factors, like what makes the pain worse and what provides relief. Is it physical activity, the application of heat or cold?
Or what home remedies, complementary therapies, or distraction techniques have they already tried?
Right, because understanding this leads directly into coordinating who is actually going to treat the pain.
Because complex pain requires a highly coordinated interdisciplinary team, or IDT, approach. Pain is processed in the brain's limbic system alongside emotion and memory, so it is never just a physical sensation.
Yeah.
It is a profound psychosocial and spiritual event.
The breakdown of this interdisciplinary team in the source material covers every angle. On the physical side, you have advanced practice registered nurses, bedside RNs, physicians, pharmacists, and physical, occupational, and respiratory therapists.
Quite the lineup.
Yeah, they're managing the pharmacopalliation and the physical modalities. But then you have the psychosocial side. Social workers, psychologists, and counselors providing cognitive behavioral therapy to help rewire the brain's response to chronic pain signals.
And if we connect this to the bigger picture, you also have to integrate the spiritual and cultural side of the team.
Oh, absolutely.
Chaplains, clergy, or shamans. When a patient is experiencing deep spiritual distress or struggling to find meaning in their suffering, that anxiety directly amplifies their physical perception of pain.
It makes it physically worse.
Yes. So a shaman or a pastoral counselor who helps resolve that spiritual conflict is actively turning down the volume of the physical pain signal. They are just as vital to the pain team as the pharmacist.
And the nursing process doesn't end once the intervention is delivered, right?
Mm.
The follow-up is relentless. You are assessing pain at every single encounter, utilizing tools like pain diaries and pain roadmaps to measure progress toward those functional goals.
Always measuring.
You're constantly monitoring for adverse side effects and titrating treatments based on real-world physiological responses.
It is a continuous dynamic loop of assessment, intervention, and reevaluation. However, and this is a big however, this beautifully structured system relies heavily on one major premise.
Which is?
That the patient has the capacity and the willingness to communicate their pain to you.
So what does this all mean when they can't or won't? This brings us to the most complex populations,
Hmm.
the silent sufferers. We've built this incredible framework for expressive patients, but the literature dives deep into the realities of assessing those who cannot self-report.
You have to start by recognizing that communication barriers are frequently cultural rather than physiological. Dr. Reed points out subcultures like veterans, the LGBTQ community, farmers, and factory workers.
Right, groups with strong shared identities.
Exactly. These groups often possess deeply ingrained beliefs regarding stoicism, vulnerability, and the stigma of expressing pain. A farmer might severely downplay a crushing somatic injury because their cultural identity is tied entirely to physical endurance and independence.
You also have populations that require incredibly specialized clinical consideration. Patients dealing with brain metastasis, severe trauma, metabolic crises like hypercalcemia, or the complex drug interactions of polypharmacy.
It's a lot to manage.
And then you have your completely nonverbal populations, patients who are intubated, post-stroke, or heavily sedated. Which brings me to a line in these notes that is an absolute paradigm shifter. It says, in bold letters, sedation does not mean pain-free.
It is arguably the most dangerous misconception in critical care. Propofol or midazolam alters a patient's consciousness. They do not provide analgesia. Just because a patient is chemically paralyzed or deeply sedated does not mean their peripheral nerves have stopped firing. The spinal cord is still transmitting nociceptive signals to the brain.
So the body is still experiencing the trauma, even if the mind is disconnected.
Yes.
The sympathetic nervous system is still mounting a massive stress response, releasing cortisol, elevating the heart rate, and degrading tissue healing. You have to treat the pain independently of the sedation.
Always. And this exact challenge peaks when assessing cognitively impaired older adults, particularly those suffering from advanced dementia or acute delirium. The literature is clear. Even with cognitive impairment, self-report is still the gold standard.
You still try.
You always attempt to get their perspective first, utilizing simplified scales and factoring in their baseline language and education. But when self-report completely fails, you transition to the 5-step approach from Passero and McCaffrey.
Okay, so step 1 is tempting that self-report. Step 2 is searching the patient's history and conducting a physical exam to identify potential causes or recent procedures that would logically cause pain. Like if they just had a hip arthroplasty, you assume pain is present regardless of their silence.
That's a very safe assumption.
Step 3 is observing behaviors. And I want to pause here. How easy is it for a dementia patient's unvoiced cry of pain to be misdiagnosed as just a worsening of their cognitive decline?
It happens constantly. When a patient loses the neurological capacity to say, my abdomen is cramping, that severe distress has to find an outlet. It manifests as agitation and behavioral dysregulation.
So what are we looking for?
You have to systematically assess facial expressions. You're looking for a slight frown, a frightened face, grimacing, a wrinkled forehead, or tightly closed eyes.
You're also assessing body movements, right? Are they displaying restricted movement, changes in gait, or protective rocking? Are there sudden changes in interpersonal interactions?
That's a huge one.
Like a typically pleasant patient acting withdrawn, becoming socially inappropriate, or displaying sudden disruptive behavior. That's throwing up a massive red flag. Even changes in sleep patterns, abandoning normal routines, or a sudden increase in pacing and wandering.
Yes, when you see a sudden increase in wandering, your first thought shouldn't be that their dementia is progressing. Your first thought must be that their nervous system is in a fight-or-flight state due to untreated pain, and they are physically trying to escape the sensation.
That is heartbreaking.
You utilize specialized tools like the brief pain inventory or the memorial pain assessment card or the City of Hope questionnaires to quantify these observations.
Step 4 is soliciting information from the family and caregivers who know the patient's baseline. They are the translators. They can tell you, he never paces the hallway like this unless his arthritis is flaring up.
The family provides the historical context that gives meaning to the chaotic behavior you are observing at the bedside.
Which brings us to the end of our journey today. We've seen that a nursing pain assessment is infinitely more complex than a clipboard and a 1 to 10 scale. It is a dynamic, ongoing investigation that requires an understanding of neuroanatomy, highly specific clinical vocabulary, deep cultural empathy, and rigorous behavioral observation.
It really takes everything you have.
You are looking at the whole human being, synthesizing their history, their physiology, and their personal goals to restore their quality of life.
And that synthesis leads perfectly into the final thought I want to leave you with today, which is step 5 of the Passero and McCaffrey method, the analgesic trial.
Okay.
Think about the profound philosophical and clinical weight of this concept. When you are caring for a cognitively impaired older adult and you have observed the grimaces, you've noted the wandering, and you've consulted the family, but you are still entirely unsure if they are experiencing physical pain because they simply cannot articulate it.
Right.
Your ultimate diagnostic tool is to administer a pain relief medication and watch.
You offer the pharmacological intervention, and you observe the physiological and behavioral response.
Exactly. If the pacing stops, if the wrinkled forehead smooths out, if the tachypnea resolves into slow, calm breathing, you have your clinical answer.
Wow.
The analgesic trial turns the treatment itself into the assessment. It proves that in nursing practice, when the words disappear and the data is completely obscured, sometimes the only way to truly hear a patient's pain is to witness their relief.
It's incredible. We started this deep dive talking about the false comfort of a heart rate monitor, the crisp, clean binary numbers flashing on a screen. But you can't plug a monitor into someone's nervous system to measure their suffering. That takes a nurse willing to look past the numbers, wade into those diagnostic muddy waters, and truly investigate. Thanks for joining us on this deep dive. We'll see you next time.